I am now going to call on Holly Graham. Holly is one of the co-chairs of this event, so while she's making her way up here, I want to know if is Jairus in the crowd? Where are you, Jairus? Stand up. Jairus and Holly were the co-chairs of our committee, and we could not have done what we have done without them. So thank you very much. I'm going to leave this to Holly.
Thank you, Lois. So I'm really excited. I've been really excited to hear everything that everyone has shared so far. That we've heard from numerous researchers and community speakers and also elders. And I'm really pleased to introduce Dr. Barry Lavallee. He is a member of the Manitoba First Nation Métis community, and he's at the University of Manitoba. I just about said Saskatchewan. It's not that we haven't tried to recruit him. He's a physician who specializes in Indigenous health and Northern practice, and his clinical work has focused on health and healing needs of First Nations and Métis communities. He also has his Master's of Clinical Sciences from the University of Western Ontario, and his research in clinical areas have focused on chronic diseases, transgenerational trauma, impact of colonization on Indigenous communities, and intergenerational and international health. He is the director of miyomahcihowin education as well. So if we could welcome Dr. Barry Lavallee.
Good afternoon. And I want to thank Mary Lee and Monsieur Norman Fleury for their presentation. It was absolutely brilliant and amazing. And for Mr. Fleury comes from the place where my parents come from. And so the words he was using, they just kind of stuck within me, and I thought, I know those words. It's been like years since I've heard those kinds of words. Because the language he's speaking is actually it's Michif, but it's you hear different words inside there. And French is very, very different, although Saint Laurent certainly was colonized by French, mostly the Oblates that transported a lot of farmers from Normandy, France, in the early part of the 1900s. So my parents attended a French day residential school and learned the fine art of self-hatred at those particular schools that really validated whiteness. And so I want to thank Holly and all the organizers for asking me to come here. And as I was listening today, there's really great speakers, and I wasn't here yesterday because I had clinic, and I thought, oh, my talk just doesn't fit inside this conference because I'm not going to talk about living well with chronic diseases, because that's a thing you actually have to talk to the community about, and it isn't a physician, even if I'm an Indigenous physician's responsibility to define what wellness looks for communities, although I can articulate it from being a member of that community. So I want to acknowledge this is Treaty 6, and the land, or the land, historical land of the Métis. And the people who spoke earlier today about Île à la Crosse, they're our ancestors from where I come from. So when you listen to them and things like that, that's part of the movement of Métis across the settler environment occurred from Manitoba to Saskatchewan to Alberta and WT, but also to North Dakota, where if a Métis person enters the state of the United States, your identity as Métis is eliminated and you become an Indian by the state. But if you also go to Quebec, your identity as a Métis is eliminated because the state does not support the identity of Métis people. So if we go to Quebec, we're either settlers or we're Indian. And it's much the same when we enter the United States, although the northern part of the United States historically have been adapted to the Métis across several states. So I really just got to say that I'm quite inspired by being here and just listening to Norman and listening to the other Métis people here. It's just been so long. So I am Métis from St. Laurent, but I have roots in Lake Manitoba First Nations as well as Pine Creek First Nations. And so the Soto culture is really quite important to me, as well as my Métis ancestry. And I'm a family physician by training. And I finished medicine at Manitoba in about 1988, and then finished my residency in family medicine in 90. And a few years later, I did a master's for 4 years at Western, well, about 10 years later, actually. And I focused on adult learning theory, as well as looking at research in Indigenous communities. And I still practice today in Winnipeg, though. I no longer go to the north. And I teach at the School of Medicine, and I teach medical students as well as residents, and I do continuing medical education for physicians. So, because in colonial society, when people come up and they have an MD behind their name and a master's and all this kind of stuff, in settler society, the assumption is that I come up here with authority in the things that I speak. I actually don't come in with authority, okay? Not in the context of settler society, actually. My family were farmers who they fished seasonally on Lake Manitoba, as well as they did Seneca route, and they were poor. And probably since the time of the late 1700s, when the fur trade actually died down and Indigenous people were no longer needed in that economy that created Canada. And so part of my work in First Nations health, not Métis, I'll clarify that, nor Inuit health, is really to kind of examine the historical roots of what we see today in many First Nations communities. And now for the speakers and the elders and knowledge keepers in the room, what I'm about to talk about is in no way to minimize, eliminate, or disguise the strengths in our communities. This is really important that you understand that, okay? My analysis is a very limited analysis, so my expertise is to look at how colonization, racism, social exclusion actually foster chronic diseases in First Nations communities. Now, I heard a number of people earlier today speak about negative and positive in the context of First Nations. And I would challenge you to actually not use those particular phrases when you're looking at participating in improving the health outcomes for First Nations people. Because to speak about racism is not a negative thing. Actually, to speak about racism is a way to clarify, is a way to add a word, albeit English, and it certainly is a word that we don't use in nursing medicine or any other medical sciences. When you look at publications across the English word, it's very uncommon to come across racism as the cause of the cause of the cause of poor health outcomes for racialized communities. And by racialized communities, I mean that if you look in any crowd in Canada, say this room right here, there are varying colors in this room, all the way from very dark to very light people. And when you racialize a group, what you do is you assign certain qualities and stereotypes to people who are different than what is considered the dominant group to settle in Canada. And that means white-colored people. And so that might be English, it might be French, it might be a whole number of things. So that the assignment of racialized groups is actually a construct that asserts white power and privilege to people who are white. But in reality, in settler Canada, what ends up happening is that whiteness actually means anybody who's not Indigenous, who doesn't identify as First Nations or Métis or Inuit. This is really important because it appears as if it's, can you hear me? Because this thing is going down. Okay. I just thought it was the state trying to shut me up. That's a common thing, Norman, with the resistance that we're doing, okay? It's a common thing. So the whiteness, when I speak to whiteness, it's not about those of you who are white-skinned in the crowd, but whiteness is a construct about you're doing it again, about the social systems that actually preferentially ensure that a certain group receive more resources than the others. And because of that malalignment and maldistribution of resources in settler society, there are significant and profound consequences to health and healing, and in this particular case of First Nations people, as well as Métis, although we don't have a lot of studies just yet on that. I am going to use a word, because I teach at the university, and Norman, if my mom and dad, qui s'appellent René Lavallee et Ella Campbell de Saint-Laurent, if they were in the crowd today alive and they were listening to this bald guy speak the language I'm speaking today, they wouldn't know who I was. So the language that you hear me speak right now is an assigned language that's actually an educational intervention for you, but not my community people per se, nor my elders, okay? So it's in the mixed crowds, and I spoke with Holly about this at length before I came, is that it's very hard to adapt this talk to support my community people, at the same time to provide a forum for education for people who are actually considered settlers. So the words are different, and I apologize for words that sound like a real munya from the university, okay? But I'll do my best. So at the university, we do a lot of objectives. You can't do anything without having objectives. So I decided to kind of mix the objectives up a little bit. And really, it's to expose the relationship between whiteness and settler Canada and the continuing oppression of Indigenous peoples, demystify settler Canada's mythology of a just and equal society, define the settler versus Indigenous binary or two-thing, and discuss how anti-Indigenous racism appears and what function it serves in settler society, to consider what role oppression plays in the higher rates of chronic diseases among Indigenous peoples in 2018, to play with the idea that elimination of racism at all levels is possible and discern what our roles are in that process. So very, very big objectives for a very, very short time. Because in gatherings like this, people come, and whenever it's Indigenous health, people want to know what's the answer? What's the solution? And I gotta tell you, I've been in the business for 30 years. Please don't ask that question again. And do not ask that question of Indigenous peoples. For the white people and the whiteness in a crowd, I want you, the next conference you come to bring a mirror. And when you ask that question, ask it to the person in the mirror, because you have the answers and the solutions to what's going on here. And so that when we look at Indigenous health, it's really an examination of the settler's role in Canadian society, how that role is developed and sustained in the context of the normalized murder and killing of Indigenous peoples in many ways in settler societies across all institutions, including health, medicine, and nursing. So there are some uncomfortable realities, and then typically when I start the first year in medicine, so I teach about 440 up-and-coming docs in 4-year periods. In the beginning, about 8 years ago, when we developed an anti-racist, anti-colonial framework for medical education at the University of Manitoba, it runs from year 1 through 4, typically with the words that I choose to use, I'd always get complaints in the office of the dean. And so the deans would call me in and say, some of us believe Canada is a good country. You know, they'd do things like that, And typically, I teach white teachers in medicine to actually teach with us, okay? But what the office would fail to realize, it was the white teachers who were talking about racism. I wasn't, but they assumed because I was Indigenous that I'm a typically angry Indian or angry Métis, whatever you want, and that I myself would actually use words like that. And so I always have to correct the deans and the associate deans at my school and say, it wasn't me, settle down, everything's going to be fine. And so what I tell the first-year medical students quite typically is that the uncomfortable reality in teaching about Indigenous health is that I teach you about yourself. Because in settler society, Norman spoke to it about the historical context of his ancestors, was that we know more as Métis about you than you know about yourself on these lands. Now that isn't a statement of arrogance, so let that go. That's not a statement of arrogance. And it's no wonder my grandparents spoke 6 languages from St. Laurent. Michif, Cree, Soto, French, English, and my one grandma spoke some Sioux. 6 languages. Why do you need to speak 6 languages when you only achieved a grade 2 in the French residential school in St. Laurent? Because our position in settler society was actually to know more about those 6 groups than they know about themselves in order to be able to facilitate engagement in a real way. Okay, so the course about Indigenous health is you getting to know who you are in the context, whether you came here a day ago or whether you came here 250 years ago. Because that uncomfortable reality about the binary, that which exists between the settler, who is not Indigenous, and the person who is Indigenous, is something that has to be facilitated, not in an act of reconciliation, because reconciliation as a word requires a couple of phenomena to occur. It requires that we as Indigenous people have the same level of power that you do in settler society, and that power be backed by resources, by monies, by land, and we don't have an equal positioning on the settler lands. So reconciliation can't occur no matter how much my heart wants it to occur until we have equal opportunity in this land. This is really important to understand. So I really caution you about asking us what the solutions are. We do know what the solutions are. We've been talking about them for a few hundred years now, except they fall on deaf ears in settler society frequently and daily. So the Indigenous body in Indigenous health is not the problem. What you might see if you're a clinician or a teacher or a lawyer or a policeman is that the phenomena of what happens when colonization attacks a body, both in a plural sense and a singular sense, is that what you observe is a consequence of colonization. So in medical school, we don't teach doctors on a book, Colonization and Health Outcomes for Racialized People. Let's examine the heart. Let's examine the pancreas. Let's examine the brain. Let's examine the emotions. Let's examine the limbs. Let's examine these things. There's nothing like that exists. And yet we train physicians and nurses and teachers and everybody to become the best they are in their colonial status in an institution. Go out and do good. And what happens? Sometimes when an Indigenous person who appears Indigenous goes to an emergency room, maybe sometimes, maybe many times, they're actually treated with respect, given the medication, or they get a diagnostic assessment, and they're said, this is the condition, this is a treatment, you'll do well. If you continue to be sick, please do come back. But our evidence shows with the Sanyas Cultural Safety Training Program at BC that this is not common. So what ends up happening in the settler society is that the normalized oppression of Indigenous peoples goes on even in front of you when you can hear, you can taste, you can touch, you can smell, and you can see. This is really important to understand. So that what appears as normal is not normal, as in the cases recently of Colton Bouchier and Tina Fontaine. One of my friends, he's a scholar in both law and medicine, and we argued the other day because another colleague of mine who's Indigenous wanted a group of community health specialists to sign a letter to go to, I forget which minister it wasn't federally, to declare that the processes that did not support justice for both Colton and Tina, that we signed it as physicians licensed to practice medicine, and to declare that this is wrong. No matter what the legal scholars say about how you select juries, etc. And my colleague said, oh no, we can't do that because we can't prove any processes in the judicial system, and we have a professional status to uphold. And I thought, that's the same bloody stuff I hear in medical school all the time. And this is about normalized oppression that leads to unwellness, it leads to murder, that people are blind to. And quite typically in the medical school, I'll put students in scenarios. I'll say, you're the student, you're the nurse, I'm the staff man, this is the patient, and I'm going to give you a scenario. So Mrs. Beardy comes from Illa Lacrosse, and she has belly pain, and she's come to the hospital at Saskatoon 4 times. The belly pain is not taken care of. Yet you as a medical student come to see Mrs. Beardy, but your staff woman goes like this, it's Mrs. Beardy. Again, it's Mrs. Beardy again. And then you want to order a CT scan to discover something in her belly that might cause the pain. And yet you have been coached as a very junior provider to dismiss Mrs. Beardy's pain. And so the student, I say to the student, okay, now I want you to play that scenario out, and I want you to confront Dr. Lavallee. I'm the doctor on that. Let's go for it. And we stand there, the 4 of us, and they look dumbfounded, right? And typically in adult learning theory, what you do is you wait 15, 30, 45 seconds, and typically the adult learner will say something, right? That's how you provoke discussion or dialogue. And the student will say, I'm afraid I won't get into my residency if I say something. And then other students will uphold that. Yeah. No, I'm worried that I won't get into surgery if I say something. Oh, okay, let's follow that through logically. Okay, so if Mrs. Beardy has developing cancer in her belly, maybe a bowel obstruction or partial obstruction, it's not important that you can actually save her life or in fact reduce her suffering. What's more important is that you not confront the settler physician because you're worried about your career. Is that correct? And typically it is. So there's an inertia that goes on in settler society about Indigenous peoples where we see something occur, we know it's wrong, and then we go to bed completely normal that night. And that's the thing that places us in the uncomfortable positions that you have to make a decision singularly and collectively about what you are going to do. Because quite typically in these institutions across Canada, legal/justice, medicine, child and family services, education, etc., it is composed of settlers who uphold words strung together as sentences and paragraphs and books that apparently dictate how we behave. In organizational theory, there is nothing as a structure. There is really nothing as an institution. There's only the human. So while the analysis I can make is that we look at structural racism, and I'm going to do that in a moment, but racism itself blends right the way through. So even as I'll show to you in a paper we published, about geography as a determinant of health for First Nations people. I argue that geography is nothing more than concealing the structural racism that is passed through institutions like First Nations health organizations, especially if you actually have no way to get out of the community. So I went through this. So whiteness isn't about white color. It's actually about social systems, structures, policies, procedures that make sure that non-Indigenous peoples get opportunities above and beyond Indigenous peoples. Contrary to the stereotype that we get step-ups. So here's the logic of how that works. So when a person who's First Nations applies to medical school, what he or she must do first is finish grade 12. They have to do 3 or 4 years of a pre-professional program. They apply to medicine. There's a process they do. They write out this, do this exam, all this kind of stuff. But when they apply to medicine, this is how it looks. Here's the settler, and here's the Indigenous person. And they have to volley this line over here. So the delta or the change is this much for the settler, but this much for the Indigenous person. And they both volley it and they get into medicine. We're in medicine now. Okay, let's study. So each exam, as well as the licensing exam at the end, you still are there. And you have to volley over, okay? Because in fact, what ends up happening intergenerationally in Canada is that whiteness is transmitted in the form of systems and services and opportunities from one generation to the next. And opposite to that, and inextricably bound, and it's hard to pull it apart, is the intergenerational oppression that goes from one generation to the next. So you have to know that Indigenous peoples can never be assigned privilege in settler society. So people say to me, oh, you're a doctor now, and all your relatives are still work on Lake Manitoba and do seasonal work. You're different, you're privileged. I'm not privileged. I am Indigenous. And if you remove my MD and remove my master's, I'm no different than my cousins. No different. People say, well, yes, you speak English well. That's not the point, because a lot of our ancestors spoke English very, very well. In fact, there was Louis Riel, who spoke many languages. He was supremely articulate in French and in English, and studied in Quebec to be a barrister, or avocat, right? A lawyer. He's supremely articulate, yet he was killed. So education is not a protective determinant for Indigenous peoples, even today in 2018. So I'd argue that point with you. So it does not refer to the appearance of the colorless skin, but rather the assignment of settler status upon the second foot hitting settler society, okay? And that's as evidence about recent refugees. One time in Toronto, they asked me to talk at a health conference. And I introduced myself. I said, my name is Barry Lavallee, here's my traditional grounds. I am a member of a internal refugee group in Canada. People, what? No, I'm a refugee because my cousins don't have access to a physician, they don't have access to jobs, they don't have a grade 12, they experience racism on a daily basis to the detriment in all phases of what a human being is. And yet we assign refugee status to people who are not in Canada yet, and by the time they come onto the ground, they at least get 4 to the 5 things that other settlers get. So it is a social assignment that carries with it very real and material things. Not that people are given houses, like, let's not go there, but they're assigned protection as a refugee who is a settler. It's not always perfect, and I'm not going to get into the argument of how racism looks for other racialized groups, because anti-Indigenous racism has a unique and specific purpose in the maintenance of what Canada is today. Anti-Black, anti-Muslim, all of those kinds of things, they do exist in settler society, but they originate from across the ocean. What's developed on these lands, this Turtle Island, is specifically and uniquely racism towards Indigenous peoples. And it has at its sole purpose the reacquisition and the raping of these lands. This is really important. One of our scholars this morning talked about how to change space and spatiality for us. But you know, I have to tell you that if you remove this very big building here called Saskatoon Inn, let's just remove it. And under here we have mud. I'm just going to tell you right now, these are unceded territories to the Indian people and the Métis people of this area. Even if there is a treaty, they are still unceded territories. So how bizarre it is that we have to make spatial arrangements and fight for spatial arrangements, be it 10 by 10, or have a speaker like me come up and talk about racism for the moment to make that space on our own lands. Isn't that bizarre? It's bizarre, but it's a continual fight. "15 minutes. I do work mostly in type 2 diabetes. I'm not a diabetologist or am I in internal medicine. I'm a family doc. But as a consequence of colonization, 20-something years after I'm a doctor, I see adults only, First Nations, really severe cases of diabetes. So I've had to develop skills around endocrinology. But also working with Nanandaway Wigamig in Winnipeg, Manitoba. And that's a First Nations Social Secretariat of Manitoba. We do work with nephrologists in looking at population-based interventions to reduce the need for dialysis 5, 10, 15 years down the road. And so we actually do use point-of-care testing. We locate disease and we assign clinical interventions immediately in order to ensure people can keep their kidneys for another 5 years, 3 years, 10 years, or perhaps die at 80-something with their kidneys intact. That would be the best thing. Because we know that keeping your kidneys actually means a reduction in cardiovascular disease, stroke, and other forms of vascular complications. So, but what we realized, because the talk around medicine and nursing was that First Nations people develop diabetes and chronic kidney disease because they smoke. They don't care for themselves. They don't eat the right foods. They don't do yoga. Essentially, they don't look white and they don't act white. And that's really the kind of logic in many ways around how we treat people. But what we discovered working with about 2,000 people in two tribal council areas in Manitoba was that at the point of conception, there's no other logical way to think about this. At the point of conception, when a baby is conceived in an environment, we should say, quote unquote, hostile, meaning that if a woman has gestational diabetes or she's experiencing acute on chronic poverty, or any number of things, the mechanisms of how colonization appears, that at the 2-cell stage, there would be evidence of less than 2 million nephrons, which are the units that compose a kidney, as well as evidence of scarring occur. And this is really phenomenal in a bad way. Because when people talk about the psychological impact of colonization and the intergenerational carrying of that oppression, we actually have evidence that there's physical consequences of ongoing colonization of Indigenous peoples that places them at risk at the age of 20 and 15 years of age. So the McDonald's theoretical experiment. If I took 1,000 First Nations children from a variety of communities, say in northern Saskatchewan, and then I took 1,000 settler children from Regina and Saskatoon who come from the most prominent, at least in terms of economic areas, and I isolated the two groups and I fed them McDonald's 3 times a day and maybe even the snacks, and we came out 1 year later, 365. And if I examined the indicators, if I examined whether they had protein in the urine, whether their blood pressure was up, whether their sugar was up, or any number of ways that would tell me that their body actually is experiencing changes, what do you think I would find based on the theory of the 2-celled human being? what we would find is that for the Indigenous children, or First Nations kids, they already would have evidence of their blood pressure rising. They would have evidence of proteinuria. As well, they'd have evidence of their sugar, hemoglobin A1C, going beyond 6.5. And we see this in our screening programs, even without eating McDonald's every day. So what ends up happening is that colonization impacts the most intimate creation of the human being at the two-celled stage, so much so that they are prepped to develop diabetes or chronic kidney disease much earlier than people who are not living under colonization's rules, regulations, and oppression. This is very, very important because it has important consequences for primary care systems in settler society in terms of actually how we look at pediatric medicine and what we do to ensure that we're keeping really tight control of the kids and trying our best. And we don't know what to do. The pediatric endocrinologists and nephrologists we work with, we don't know what to do. We don't know if the medications we use for adults should be used in pediatrics. This is a new emerging phenomena of how colonization looks. Oh, how many minutes? 10? Okay. So this is a publication that we did. Remote dwelling location is a risk factor for CKD among Indigenous Canadians. We had to fight really tooth and nail in this particular publication to include the word racism, because the logic behind this particular publication, and with my colleagues, was that geography itself is an independent risk factor for Indigenous peoples. So if you come from a really isolated community where there's only air access versus an intermediate where you have a community, but you could drive out all year, and then you have Indigenous peoples who live in Saskatoon, or in this case, Winnipeg. We examined those same indicators. And what we found was a gradient, that if you're born and raised in a remote area, that the chances of you developing chronic kidney disease are higher than the intermediate, higher than the urban. But for the three groups examined in this publication, is that they still are higher than settlers, even if you live in Saskatoon or Winnipeg. But what really it talks about is that when you are isolated under the control of the federal government, and that camera should get that, the federal government of Canada, when you are isolated under the federal government of Canada and you are a racialized group called the First Nations people, it has consequences on your physical health without even having precursors like diabetes or hypertension. Because the screening we did in those particular communities were from 10 to 80, and you didn't have to have a precursor for chronic kidney disease, but you still had chronic kidney disease. So it's a theoretical model. People say, oh, do you have evidence? Well, it's a theoretical model, so let's do a little bit more work. But anyway, so if you are interested, I could send that to you. This is actually a decent publication. So really, what is this about? It's about unveiling the targeted body. It's unveiling the targeted body and making what is normal not normal, and what you're blind to, I'm going to unblind you. This is what it's about. So it's not about, in the case, like at my medical school, we do not talk about culture in the context of celebrating the unique cultural aspects of who we are as Indigenous people. Because the culture for us in medicine is really the culture of violence that goes on against Indigenous peoples. That is a practice that is reinstituted and recoached on the wards at the Health Science Center to the people that we teach. So by the time we finish with them in Med 2, they go to Med 3, they come back to us during that clinical time. They are about as resistant to looking at themselves as they ever were. And because they go into systems that actually reinforce the same stereotypes about Indigenous peoples. So we have proposed in Manitoba about the development of policies that will eliminate, at least on paper, racism. Does it work? We don't really know. Will the Manitoba government accept it? We don't really know. The colonial governments do something that's called slow time. It's called benign neglect. So no matter what you say, because we have all the evidence, we have publications about how cheap it is to actually screen people for chronic kidney disease across Manitoba on an annual basis at less than $2 million a year versus actually waiting for downstream costs to the provincial system in Manitoba running into the tens of millions of dollars for dialysis. And we have evidence of that, clear settler knowledge evidence. And the governments refuse to move on that, refuse to move on it. So one of the really sad things is that all the evidence we have from the master's tools that we use is not listened to by the government nor the state. So there's a lot more work to do on that to be able to address Indigenous health. And the elimination of racism is one such area that we need to move into, because racism kills. Thank you.
We wanted to ensure there's 15 minutes for questions, comments, and whatnot. So this is your opportunity to ask Dr. Lavallee some questions. I think I have both the mics up here for those, or you've got extra ones there? Okay, thank you. I think, you know what, while you're thinking of your question, you know, for me, as I'm thinking that I know I stand corrected with my Cree, we talked about the last session, healing with culture with Inuits, and help me out there, Norman. Gas, egwa, Inuits. Gayas, egwa, Inuits. So we talked about gas in the past. So we've heard a lot about our Indigenous worldviews and the richness in the culture and how it used to be in our land and whatnot. And it was very eloquently described, and we were all very much engaged and very enthusiastic. And right now what Dr. Lavallee is talking about is Inuit, which is right here, right now. So I don't know what you're feeling and what you're thinking with what you've heard, but I hope whatever you're feeling and thinking is motivating you to look at what we can do now. We've been given a lot of the richness of the culture through many peoples who have come here to share, scholars, elders, and community members. And that was to, I don't know, like in terms of theoretical constructs, to give us some ideas of what to work towards. What I appreciate about what Dr. Lavallee has to share is the reality of the challenges of where we are today and what we're exactly facing. And this is the uncomfortable part when we look at the history of the relationship between the Indigenous and non-Indigenous peoples. And it is uncomfortable. And that is part of reconciling. And we've had many conversations about that term, you know, reconciling. And, but that's a term that we've come to use to have this common understanding, to have this discourse and this dialogue and that. So I'd really encourage you to maybe share a comment or to ask Dr. Lavallee to have the opportunity to further, you know, clarify one of the concepts or whatever you may think. Okay, I see someone over there.
Hi, thanks for this great presentation. Like everybody in here, I also was enjoying. The question I would like to ask, like what I learned from the interaction with few communities, like you may agree that social health and mental health, or the physical health and social health, mental health are all connected. Both are connected. So then when their foods are coming from the south and going far north, like south end, it is not in the same line with Thompson in Manitoba, almost close, like, you know, Reindeer Lake. So I was surprised to see that every day, 2-3 trucks are going to dump their food. And you know, just you have all this history. At 1963 or sometime, they have very few people suffering from the diabetes. Now, from the 80, it has gone like skyrocketed. So it is all, connected to the food, that would be the starting point. So if we allow the market force or the institution to influence their health or, mental health or physical health, influenced by the food, if they're sick, then their mental health would also be affected. The physical health, like if they're unhealthy, they will not feel good. So how can you just address this issue? Like how can we just fight this market force that is changing the foodscape?
So just give me a brief question on that. What are you asking?
The market is changing their food system. Like now we are dumping all this food to southern. It is far away, like 700 kilometers from the Saskatchewan. So every day they are getting their food. I asked them, I thought like that would be a community. They are relying on the country foods. But then I found a different scenario that is not very far from this city. So I asked them like, why do you eat this food? Then relying on this country food. They said, I like this crispy chicken. So this is how their food system is changing, and it is, I believe this is making them unhealthy. So how do you just deal with this? In one side, we are putting all this food coming from these stores, and then we are trying to make them healthy. So kind of disconnection, I think.
Yeah, well, we don't actually tell them what to do, is first thing. But our elder, Mr. Fleury, spoke about traditional foods and their utility when he was a child, and kind of what he heard about what his grandparents did. But he also talked about the fur trade and the creation of a false capitalist system on Indigenous lands. This is really important to understand, okay? The creation of a false capitalist-based system on our traditional lands, and how subtle that actually occurred over hundreds of years. So that according to Daschuk from University of Regina, by the time, he mentioned it, by about 1770, 1780, people started seeing a depletion of protein sources on the lands from here, maybe towards Manitoba a bit, all the way to the Rockies. And that occurred over decades. And intermingled with the loss of protein, I'm talking about small protein sources that you find in the prairies, was smallpox, influenza, and a whole assorted invasion of viruses and bacteria that came from generation to generation. So in that particular wake and make, indeed people, and my parents in the 40s and 50s still ate country food in St. Laurent. It was deer, rabbit, and fish, and not moose, or I think they were further north by then. They still did. But that the introduction of the foods occurred not crispy chicken, okay? That is a very late entry. You have to look at this as an historical phenomena that has consequences and actions and behaviors today. This is really important, because if you don't look at that, then the answers appear quite simple. And this is the problem with medicine and nursing, a very uncritical, I gotta tell you, professions. There's not critical professions, okay? Because you make the assumption that one person in 2018 who eats this particular food, and I say, don't eat that food because it's no good for your diabetes, that's the solution. That isn't the solution. My whole talk today was really about understanding the origin of how oppression actually develops and is maintained and sustained, and why it's maintained and sustained in this capitalist system called settler Canada. So if you're wanting to ask the communities what is the best way for better health, we have tons of information, tons. But you have to understand that in research, we in our communities are not allowed the $1 and $2 million prizes to actually articulate the ways to better health. We have a program at Nanandawe-Wigameg called the Indigenous Doula Program, which is a brilliant program about Indigenous women reasserting their roles as support people to women who are having babies. Brilliant. It has nothing to do with my ability as a physician to deliver a baby. It's about sacred connections between a woman at the point of conception till she delivers her baby in the context of her family and the supporters. And that is what good eating is about. So my long and short answer is, don't look at the immediate thing in 2018, February 10th, that you see. You have to look at it in a broader context and take a critical view of how this forms. Certainly, eating a lot of high-fat foods, if your energy consumption isn't a good idea. But I'll tell you right now, when we do lectures up in northern Manitoba, and we're thrown out by our communities, and rightly so, when we say, just go back to country foods, go trapping. And they'll look at you and say, well, how would you like me to go negotiate with Manitoba Hydro for access to my traditional lands first and foremost? Because that's where my lands actually are. So I can't go back to traditional foods because of the impact of colonization on our lands. So the point being that you have to be critical, not to hurt yourself, but to look broadly at what Indigenous health is about. And it's not simple in that context.
Barry, I have a question for you, and thank you for your talk.
No, you don't. Just kidding.
So I have a question, and it's a question that I've been grappling with, and I've talked to many elders about it, and that's about this. So,
Technology.
So technology, but not only the smartphone, right? And so my question is this the new colonizer?
Everything is the new colonizer, including technology.
But I'd like you to go further into that. I mean, we have a group of students here, and I'd like you to talk more about that, because when we look at this piece of technology, I was just at a conference where somebody from IBM spoke, and they said, we look at our phones 700 times a day, and we swipe them 2,700 times a day. And that's on average, so they're able to keep track of this. So while we often talk, and we do for good purposes, talk about history and colonization historically, is this, and it's not only, I think it's Indigenous people, but it's also everybody, that there's this new power, and it's a power that we enjoy, but it's also that it tells us what we like, it tells us what we should like. And so my son, I have an Arab Métis son, and so people ask me, what's his culture? And I say, I think it's consumerism. Because he consumes. His life is about consumption and because he is told what he likes, and he's directed in ways that we weren't directed, and it scares the hell out of me, frankly. And so I talked to elders about, what is this, and how should we be problematizing this through the lens of colonization, and maybe that's not the correct word, but it feels like it.
Well, when I go up north about 17 years around to Tatasqueyak First Nations, and the white colleagues that I was around, over the generations that they come and go, would always make comments, and it's a comment of violence. They're supposed to be poor here at Tatasqueyak, and yet I see all these big 4x4s and skidoos. And it's a common thing, eh? I see all these big 4x4s and skidoos, so ... therefore, they're not poor, ... therefore, they're actually not impacted by colonization, ... they make choices about their health and healing that appear paradoxical in the context of living in a community where they have, for now, that I've been there it would have been 17 years, I've seen people in the same house that's not corrected for 2-3 generations, right? And yet they have big new trucks. My question is why shouldn't our children have access to the same new technologies that other kids have access to? And why do they have to then contend with the fact that they might come from communities that are poor, and so therefore I can't have technologies? I have a real problem with that. But what I've become aware of, because of some of the work that's done by my colleagues with youth, Indigenous youth in Winnipeg, is that our Indigenous youth are just as creative as any other youth. And they use that technology in remarkable ways to articulate who they are, what they want, and where they want to go. And they do it as leaders. So I personally won't let my grandchildren use technology. All right? That's just my personal thing. In my house, they don't use technology. My kids didn't use technology. That's just my thing, okay? Although they're adults now, I can't tell them what to do. But I think when we flip it over and say that they have the right to use the same technology as other youth, despite what we know, that's a place you have to sit with. But I don't think we could push that onto our youth, that it's a tool of colonization, because they will adapt to it and create their identity, and will see their identity through that. And I think that's the thing that I hold on to, even if I want to. I'm not going to take a real analysis around technology and colonization, because it actually dismisses and it might undermine their beliefs around use of technology and the expression of who they are as Indian and Métis kids.
Getting so many comments, Barry. I just want to read them. They're just awesome, and maybe we'll get some. So, whoops, sorry.
You're pushing me.
Physical. Yeah.
Just kidding.
Okay, can you recommend resources or publications that could challenge settlers in identifying and understanding suitable adoption of colonization and racism ideas? Subtle adoption of colonization and racial ideas. Our institutions pay a lot of lip service to these ideas of reconciliation and indigenization. Many Indigenous people and allies recognize that there's a lot of work to do if we're ever going to make productive progress in these directions. Excellent discussion about oppression and racism and uncovering and exposing the truth. We have a long way to go yet before we can all talk about reconciliation. Thank you. As a settler, I would like to thank you for speaking the truth about the realities of our nation and our whiteness, and to say that there are many of us who accept the truth and our responsibility to address it. Do you find your work with medical students is helpful in creating culturally safe care, or care that is not racist? And how do you combat the small racist actions and statements that made by individuals that further perpetuate the larger racist attitudes in the population? Maybe you want to pick one?
Which one do you think?
I think maybe the resources, right? I'm hearing a lot, maybe resources to direct people what they could read, further enhance their knowledge for both.
Number one, get a mirror. Okay? Make sure that your face can actually fit in that mirror. And number two, look in that mirror. Okay? And you'll find the resources. Part of the difference between competence and cultural safety is that competence is a set list. Check, I spoke to an Indian. Check, I spoke to a Métis. Check, I know what languages they know. Check, I know the lands that we stole from them. You know, just go on and on and on. And A+, now I leave in my world. But actually safety, despite what people say, is about self-reflective activities. It's about your ability to unburden yourself of the thing that you're actually trying to hide all the time. Shireen Razik, who's a brilliant, brilliant scholar, and I'd recommend Shireen Razik. She's at UCLA right now, but she came out of OISE at U of T. She's a brown-skinned Muslim woman. And she's done really excellent critical work about the station of women in settler society, especially Muslim women. But she also did a series of articles and a large text, around Indigenous men dying in custody. And in Saskatchewan, you know, that's a Starlight Tour. She's written about that. But Razik says that in Canadian settler society, that the settler is compelled, and this is kind of not verbatim, okay? You have to read her stuff and read into her stuff. She says that the settler is compelled to attend a conference on Indigenous health. Is compelled, but doesn't know why deep down, although knows that something's wrong, something's the matter. And you're compelled, she says then, to really go to the grave of the dead Indian. And I don't say that as disrespect to my First Nations cousins or my mom's people, okay? I'm using the phraseology to provoke you. So you're compelled to go to the grave of the dead Indian, and you kick at it, and you pull away, and you kick at it. And you sit there in paradox, in uncertainty about why am I here? But like Gandhi said about the English during the British wars and the British oppression of Indians on the continent, Gandhi knew one thing, that no matter how the English killed the Indians, the peasants, he knew that when he went to Great Britain, they had a heart. Isn't that phenomenal? I thought that was brilliant. Gandhi knew that the white overlords had a heart. And that's much like what Razik says. So your resources really are the emotive response you have to these uncomfortable positions we sit in. And why are you compelled, beyond your boss telling you to come over here, listen to what Holly and her crew have to say? You are compelled by another force to be here. I don't have the solutions for you, neither does Mary Lee nor Mr. Fleury. They have to be within the mirror, and they have to be in your own context, because we're not the problem. The Indigenous, we're not the problem. We never have been the problem. But you got to figure that out. And I got to go.
Well, thank you so much for that thought-provoking and clearly outlining our steps for us to go and directions we can all take in the communities that we represent and places that we come and places that we're going to go. So thank you so much for taking the time to deconstruct that so eloquently and in a way that excites me that we're having these conversations now. I know 10 years ago this wouldn't have happened, and 20 years ago it was unheard of. And so that's one thing that warms my heart, to think that we're at the point now as Canadians that we are willing to open our minds and our hearts to different ways of thinking and being, and open our hearts and compassion and feeling to understand other ways of feeling and being as well. So I thank you, everyone who's listening, and I encourage you, like Barry said, is to get a mirror, and I do that every night myself. It's the only way I can grow and develop myself as a human being, is if I'm very honest with what I see when I look at the mirror. Sometimes it's hard, but that's the only way we can progress and look at all the steps that we have to take. But we're starting it by coming here and having this conversation. So thank you to all of you. Hi, and Barry ran away before I gave him his gift.